So the medical school is based in Brighton, which is where that cheese is at the bottom right-hand side of the country. It was set up by Professor Subhi Banerjee, who was the person responsible for writing the dementia strategy within England. So one of the reasons I joined the unit was very much around kind of applied dementia research. So using research in ways that can improve the quality of life and well-being of people with dementia. And we do that through various large-scale studies. I've put a few there, such as Determinants and Stride. And we also have a really novel educational program where we teach our medics, or we take our medics, trainee medics. They work alongside people with dementia and their families for 2 to 3 years as part of their training through the time for dementia as well. So all of our work is around improving the well-being and quality of life of people with dementia. So today I'm going to talk. I'm going to talk about one of the work streams within the determined program of research that's looked specifically at the diagnostic timing. And we have now pretty much hot off the press really had a look at our baseline data, so the point when people were diagnosed, to see who is accessing an early versus a late diagnosis, and a timely versus an untimely diagnosis, and to have a look at whether the diagnostic timing has any associations with people's life quality and well-being at the start of their post-diagnostic journey with dementia. As I mentioned a little bit at the start, it's determined is a cohort study. It's funded by the Economic Social Research Council and National Institute for Health Research, and it was set up in 2019 with a number of university partners, which I've listed at the top of the screen. There's also a website, and which I've listed again at the top left of the screen if you're interested in finding a bit more about it. But we began recruitment in 2019 in June, and unfortunately we had to stop in March 2020 because of the pandemic, at which point we had about 300 people who had a recent diagnosis of dementia within our study. It then took us, we had a break of a year, and then it took us another 2 years until the end of 2022 to recruit the remaining participants. So we have one big cohort of 940 newly diagnosed people with dementia and 750 of their care partners. And within that cohort, we have some who were recruited pre-pandemic and others who were recruited kind of post-pandemic, or sort of 2022, 2023. And we have a number of work streams, which I've listed there, work streams 2 to work stream 6, which feed off the data that we collect from participants. So we ask them, we have yearly visits to their homes, and we ask them how they're getting on, what their health is like, what their quality of life is like, any services they've used, and run a number of other measures and questions with them to enable the different work streams to answer their questions. If people are interested, please do go and have a look on our website. The bit that I'm going to talk about today is this one here, work stream 6, which is looking specifically at the effect of the diagnostic stage on people with dementia. And this is one that I head up with Professor Subhi Banerjee. So why is it important? Well, certainly within the UK, and many global policy directives at the moment are encouraging people to seek an early diagnosis. And it tends to be that people suggest that this helps people to understand what's going on, provides them access to support and drugs and non-pharmacological interventions to help them. And it's part of their human right to know and understand their condition. So it does seem that potentially an early diagnosis may be beneficial for people, but there isn't a huge amount of evidence around at the moment that outlines its benefits. A couple of important points just to clarify. When I talk about an early diagnosis, I'm thinking about the diagnosis from the kind of medical perspective. So this is about intervening, or diagnosing and intervening when the condition is at the earliest stage in terms of cognitive deterioration, or within this kind of pre-symptomatic, early symptomatic stage. So it's very much from a kind of biomedical discourse. And there's a limited literature at the moment that seems to suggest, limited literature with limited evidence on the beneficial impacts. And if anybody's interested, the Alzheimer's Disease International produced a report way back in about 2011, I think, and found only 2 papers. And there's been very little since then looking at the benefits of an early diagnosis versus late. In response to this kind of lack of evidence, more recently, there's been an emergence of what's called the timely discourse, or people accessing a diagnosis when it's timely. So this is very much a more kind of person-centered approach to receiving the diagnosis. So it's about accessing the diagnosis when it's best for the person, the family, and the healthcare professional. So it could mean that for some people, getting a timely diagnosis is at the earliest point of the condition when they first notice the symptoms. But for some people, they may not want a diagnosis. They may never access a diagnosis. So for them, that is also a timely diagnosis. And some people may live with the conditions for a while and then seek a diagnosis. So again, a timely diagnosis is very, very subjective to that particular person. And it involves working together with the clinician, the person living with the condition, and their family to come up with the best kind of timing for delivering this diagnosis. And this is a new kind of trajectory or discourse within this field. And so there's some emerging, but again, fairly weak evidence to see to assess whether a timely versus an untimely diagnosis can be beneficial for people with dementia and their family. What do we do within Determine then to start to test some of these or explore some of these areas? Well, we first of all divided we created some indices to measure both early diagnosis and timely. So first of all, we created a temporal measure of early diagnosis, and we asked our participants when they first noticed some symptoms, the first kind of initial symptoms of what they thought was dementia. And then we had their diagnosis date, which was the point when they entered into our cohort, or within 6 months of entering into our cohort. So we had the diagnosis date and when they first noticed their symptoms. And what we said was anybody from 2 years or earlier, so would be classed as an early diagnosis. So when they first noticed their symptoms to receiving a diagnosis, if that was within 2 years, that time span, then we class them as an early diagnosis, a temporal early diagnosis. We were also able to create an indice around a cognitive early diagnosis, and we gave people a cognitive measure called the mini mental state examination, which is marked between 0 and 30, and scores between 20 and 30 tend to be classed as mild dementia, so early dementia. Between 10 and 20 is classed as moderate, and lower than 10 would be classed as severe dementia. So we were able to group our participants up on our cohort, and those who scored 20 and above as early diagnosis, and everybody else as a later diagnosis. So that was another index of early versus late on a cognitive scale. And then timely, we also asked people what they thought about the timeliness of their diagnosis, whether they felt it was made at the right time for them, or whether it's made too early or too late. And we split our cohort up again here between those who said it was about the right time, and we classed them as timely, and those who said it was too early or too late, and we said they were untimely. And then our LSE team conducted a range of analysis first to answer questions around, well, who is accessing timely and early, and who's accessing late diagnosis and untimely diagnosis. These may look a little bit complicated. I'm going to try and simplify them, but please, if you've got any questions, stick them in chat or we can come back to them. But so this is we created a model to look at which of people's socio-demographic characteristics were associated with an early versus late in the cognitive scale. And what you can see here is that ethnicity seemed to have a direct role, where white British people within our cohort tended to be associated with a cognitively early diagnosis. You can also see that older people, or age and socioeconomic situation, also tended to be associated with diagnostic outcome timing. So older people, and particularly those from lower socioeconomic status, so those who are in low occupations, don't own their own house, are claiming benefits, tended to be associated with a later cognitive diagnosis or a later diagnosis. So this exploratory research. So we've sort of posited a number of reasons why this may be. There could be some issues around like cognitive reserve, where people who have developed cognitive reserve over their lifetime. So this is the way that your brain can adapt to changes. So you tend to develop this through higher education or keeping your brain active, socially stimulated, physical activity, jobs which are kind of varied and flexible, things like that, ways to develop that cognitive reserve, learning a different language, things like this. And there is some research to suggest that people who have that can be a protective factor against dementia, but it can also support people in those early stages of dementia to live longer with it, with the condition or with the symptoms of the brain, being able to adapt to that. It could also be the tools that we used, and potentially they're not culturally appropriate. So some people who are a non-white British, so from different ethnic backgrounds, we may not be picking up, or the tools may not be culturally appropriate for them. So we may be recording them as having higher levels of cognitive deterioration than perhaps they have. Maybe this is actually due to language difficulties or cultural understandings of the questions that's being asked as well. And we've also suggested that potentially some of the older people may view dementia as a natural part of aging, and therefore access a diagnosis when their cognitive deterioration has got more severe, and suggest that again this kind of taps into literature around raising the dementia education. What's interesting though is that when we use our other outcome measure of early diagnosis in terms of timing, we get some very kind of contradicting and different results. So here you can see, here's where we've classed people who first noticed symptoms and then received diagnosis within 2 years as early, and looked at who's accessing that. And you can see here that those white people, white British people, who are more likely to live in rural areas and sit within higher socio-economic situations, higher education, lower areas of deprivation, more affluent areas, tend to report a later temporal diagnosis. So on one measure, they're recording an early diagnosis on the cognitive one, yet on another measure of timeliness, temporal diagnostic timing, they're reporting a later diagnosis. You can also see that more highly educated people with dementia tend to have more higher educated carers. And again, this is associated with a later temporal diagnosis of dementia. And you can see in that top right corner, there's something about our pre-pandemic cohort. So those people who were diagnosed before the pandemic kicked off tended to be associated with an earlier temporal diagnosis compared to people we recruited after the cohort and after the lockdown. Some of the reasons here we've sort of suggested is more highly educated people may be noticing those symptoms earlier, may be able to pick up on the symptoms and the brain changes, but decide that they want to live with it longer. And some of this might be attributed to the stigma we know that can exist around dementia. A lot of them, or some of these people, live within rural areas. And again, if you're losing your driving license with a dementia diagnosis, then that may restrict people's ability to engage with the community and to socialize. And therefore, people may be choosing not to receive a diagnosis and to live with it longer in order to keep their driving license. We also suggest that there's potentially some challenges around rurality, lack of services to actually offer that diagnosis, or GP services to forward on people to specialist services where they can receive a diagnosis. There's also here the pandemic effect, as we've recently been we've recently written the COVID inquiry report for our government, and certainly one of the areas that came up within that is whether people are now receiving a later diagnosis because of the pandemic and the backlog of people who've had to live with it much longer. And certainly this is one of the first bits of evidence that suggests we may have a bit of a pandemic effect here. And there may be some issues here around ethnic population. Within the UK, we are at the moment having screening programs where we are targeting people we know may have challenges when accessing a diagnosis. And this may suggest that some of these screening programs are working, where there's some increased attention, particularly in our London areas, on populations, ethnic populations, seldom heard populations, or hard to reach groups that we know have challenges getting diagnosed, these screening programs may be working because it's suggesting that potentially in terms of the timing wise, they are receiving an earlier diagnosis compared to others. And then again, we mapped out what it looked like for timeliness as well. So here again, these are quite interesting findings, but it suggests that older carers and those from lower socioeconomic backgrounds are associated with reporting a more timely diagnosis of dementia. So although older people are accessing a diagnosis at a later stage or a later diagnosis, they tend to report it more as a timely diagnosis of dementia. And again, we've suggested that perhaps if people are feeling nothing can be done, then perhaps a diagnosis is viewed as timely, depending on when people get it. Sorry, I'm just admitting something. There's also research from Wendy Hulko, who I know works out in Canada, who's looked at kind of lower privileged backgrounds, people living with dementia from lower privileged backgrounds, seeing the condition as no real big deal in relation to other aspects that other kind of discrimination and prejudice they may have faced. And so they tend to just kind of get on with it, and they've kind of developed this level of resilience to help them get on with it. So we've suggested that perhaps when they do receive a diagnosis, or when they do tend to then access services, they then report it as timely for them. So there's a number of kind of reasons we've kind of posited or explored as potentially why this may be the case. But I think some of the key messages I would like you to take from this is that there are kind of multiple and sometimes contradictory effects of background characteristics, depending on the way that we measure early versus late and timely versus untimely. So I think what this shows, or what our research is showing here, is the outcomes are certainly measuring different concepts. So temporal early diagnosis is different to a cognitive early, and they are both different to a timely diagnosis. So I think this has important implications. So it's really important for both policy and research to clearly set out how they are operationalizing or how they are defining and measuring early diagnosis, so we can start to compare findings. So it's likely that if you are using your measure of early diagnosis is on the cognitive status, someone and another paper is looking at it from a more temporal or time point of view, you're going to get different findings. So it's going to make it more difficult to compare. And what this also shows is that early diagnosis doesn't necessarily equate to timely diagnosis. And so papers that papers and policy practice that interchangeably use these concepts early and timely just need to be mindful that actually we're talking about two very different constructs here. And there seems to be different pathways of timeliness for people with dementia and their carers. So I only showed the carers' perception of timeliness there. We do have other data around person with dementia's perception, and you have to take my word for it, but there's a different pathway for people with dementia here. So essentially suggesting that timeliness for the person with dementia doesn't necessarily mean the same thing as timeliness for carers. So there's something we need to explore there. And then for our second bit, once we'd figured out who was accessing an early versus late and timely versus untimely, we wanted to see whether it had any associations with their quality of life and their well-being. And we measured this in various different ways. So at the Brighton Sussex Medical School, we developed our own dementia-specific measures of quality of life. So the DEMQUAL, the first one there, is given directly to the person with dementia, and higher scores mean better quality of life. The DEMQUAL proxy is given to the carer, asking them about their perceptions of the quality of life of the person with dementia. And the CDEMQUAL is a dementia carer specific quality of life measure that's given directly to the carer. We also had other kind of more global measures of well-being, such as the EQ5D, which is health-related quality of life, and our Office for National Statistics measure of well-being and anxiety. And we also use the carer burden scale. So what do we find here then with our outcomes? So bearing in mind, this is at the point of diagnosis, and this is cross-sectional data. So it's just at one point in time, just after that person has received a diagnosis of dementia and their family member has received that diagnosis of dementia. So this is from the person with dementia's perspective, so our 935 people here. And what you can see is there's not a lot going on, really. There's very little. There's non-significant findings in terms of early diagnosis from the point of view of when people first noticed symptoms to when they first got the diagnosis. There's quite a few negative effects there, but none of them seem to be particularly significant. And there's a little bit of significant finding here about if the person with dementia felt that the diagnosis was timely from their point of view, it tended to be associated with a small increase in their own self-reported measure of quality of life. Interestingly, if the carer felt the diagnosis was timely, the person with dementia tended to report a lower, significantly slightly lower level of quality of life, which is quite an interesting finding in itself. And then when we looked at the outcomes for the carer, you can see here there's a lot more going on, particularly within the timely carer. So if the carer perceived the diagnosis as timely from their perspective, it's associated with significant findings across all of our measures of quality of life, our measures around well-being, satisfaction, and lower levels of carer burden. And there are some other findings which I've highlighted in green and both red there. Green is positively associated, red negatively associated. But you can see as well, if it's early in terms of timeliness, early in terms of the temporal measure of early, then this does again seems to be associated with some quality of life and well-being, positive quality of life and well-being from the carer's perspective. So there seems to be a lot more going on for the carer, particularly when the diagnosis is perceived as timely for the carer. What are the sort of key messages I'd like you to take away from this? Well, again, this particular research again showed there was an agreement was poor between our early diagnosis indices and our timely diagnosis indices. There's very little correlation between them. Again, suggesting, as we found in the first study that I was talking about, there is a real difference between these constructs. So we need to be real mindful of how we use the terms. And again, there was very little correlation between the person with dementia's report of timeliness and the carer's report of timeliness. So again, timeliness seems to mean something different for the two different parties involved. Again, as I mentioned in the first study that I talked about, the way we conceptualize that diagnostic point has implications for short-term well-being outcomes after the diagnosis has been delivered. So generally at baseline, so this is at the point of diagnosis, timeliness seems to be more associated with better well-being outcomes, particularly the case for carers, rather than early, where our findings seem to be a little bit more mixed, rather than the early versus late, where our findings are a little bit more mixed. Interestingly, our kind of measure of temporally early was associated with generally negative outcomes, although these weren't particularly significant for the person with dementia. So perhaps it's that the person with dementia maybe didn't have enough time to prepare themselves for that diagnosis. If it was given too early from them, that might be responsible for some of these negative outcomes. And there's certainly some support in our work from academics such as Bob Woods, who talks about the move towards a kind of timeliness diagnosis and how that may be more beneficial for people. So again, we can offer a little bit of support on that, again with the caveat though, this is very much cross-sectional data at this one particular time point immediately after a diagnosis is given to somebody with dementia. It's also really important to be mindful that there are very small effect sizes for these associations as well. And therefore it's likely that whilst diagnostic timing may have some beneficial impact, we need to look more widely. Policy directives are likely need to look more widely at that diagnostic process, particularly around the quality of the way that diagnosis was disclosed to the person with dementia and their families. So as I've mentioned throughout, please, with caution in terms of our kind of cross-sectionality, it could be again that there could be some kind of reverse causality here, that if people do have a positive outlook, then they are less likely to respond negatively. If they had a positive diagnosis process, then maybe they may respond more positively. And again, we're only exploring that first part of the person's post-diagnostic journey. Again, our conceptualization of cognitive early could be flawed. It could just be a representation of cognitive performance. As I was saying previously, there could also be some issues and challenges there around kind of cultural measures, cultural appropriateness of the measures we used for that. And our measures of timeliness don't allow us to understand whether a diagnosis that was too late was due to healthcare systems and failures within the healthcare systems, which again could impact on people's perceptions and mean that they report more negatively in terms of their well-being. And it has nothing to do with that kind of diagnostic delivery. It was more about the healthcare systems. What are our future plans then? Well, we are still following people up until the end of this year, and where we'll have then 3 years worth of follow-up data from them. So at this point, we are now at the moment mapping longitudinally outcomes associated with an early versus late and a timely versus untimely diagnosis of dementia. And I think our findings from this will have some really important implications for policy and practice, and particularly as the policy that is pushing for early diagnosis at the moment. I think we really need to understand whether this is going to be beneficial in the short, medium, and long term for people, which we will be able to answer through determinants. We are going to set about looking at to try and better understand what timely means for people with dementia. So qualitative work here, interviewing people about, exactly what does a timely diagnosis mean for people with dementia and their carers, and to compare that qualitatively, and also through our kind of surveys, open-ended surveys and things. We also have a PhD just started that is going to develop a diagnostic develop a tool to measure the clinician's competencies when delivering a diagnosis of dementia, to understand how we can measure it, what constitutes a good diagnosis delivery, how we can measure it and use it within determinants, to then see whether it has any associations with better well-being and quality of life for people as we move forward. So I will end on that. Thank you very much. If you're interested, that's the website. We're on the social medias and things like that, and there's my email as well. So please do get in touch. And I'm just acknowledging everybody that's involved in the study. It's a massive study. And it's been a real pleasure to kind of be involved in it and to manage. So I will stop sharing now for some questions, hopefully.
Alex?
Should I go ahead?
Yes, please go ahead.
Great. Thank you, Ben, for this presentation. I have to admit I found some of the data to be, I guess, beyond my level of comprehension. So let me ask you, can you hear me okay?
Yes, sorry, absolutely, yeah.
Okay. Let me ask you this, because your future slide actually sort of answered one of the questions I had, which was, how do you define timeliness? What does timeliness actually mean? And so let me ask a question that might help. Let me turn on my camera so you can see. That might help you in answering it. And that is that, did the study look at taking a cross section of the population? So let's talk about the British white cross section and saying, okay, we're going to start testing people from the age of 65 and up, and capture and categorize how many of those people who at the age of 65, I'll just go by 5-year increments, 70, 75, 80, 85, demonstrated or exhibited dementia. Did that even...
We didn't. There is a study called the Cognitive Function of Aging, CFAS, and Carol Brain is who's based at Cambridge University, is one of our collaborators on this project. So what they have done is exactly as you've said. They've tracked people over time, and looked at their symptoms as they've aged, and then they've looked at whether people receive a diagnosis of dementia or not, and they can give them a diagnosis of dementia. So they're looking at whether how much dementia is picked up within the wider community, essentially. But they also have some well-being measures there. And interestingly, Carol found that people, when they first were diagnosed with dementia, report slightly lower well-being and higher levels of anxiety compared to people who at a similar age and controlled for who didn't receive a diagnosis but had similar kind of cognitive challenges. So again, this is that initial impact. So we recruited everybody who had a diagnosis of dementia. So they had to have a clinical diagnosis. We recruited across England. So that's something I should have said. Sorry. We recruited from the south, from London, and from the north in Newcastle deliberately because we wanted a diverse sample in terms of geographical location, in terms of ethnicity, in terms of kind of social deprivation and things like that. So we've got a fairly diverse sample, within that.
Right. So if I understood you correctly, well, let me ask the question. Did your study, did it get compared to the study that the other person you mentioned looked at the age? And so, for example, if you, for example, in your first slide, you says, okay, the British white population, we had early diagnosis because of education, etc. Did you compare that result with the age study that said, you know, 60 and beyond? And how did that? Yeah, sorry.
That's a work. Yeah, no, that's a work in progress. It's a really good question. It's a work in progress. So the reason Carol Brain is on our study is to do exactly that. So some of the measures we used were similar to the measures that she used within her study. So it means that we can start to see how our cohort compares to her cohorts that over the time period as well. So it was deliberate, and that's why we use some of those measures as well. So that'll be very interesting. Yeah, and that's a work in progress.
And one last question, if I may, and I don't want to monopolize this, but I'm very curious. So really, the study of diagnosis or early diagnosis is dependent on the participant, meaning that if I'm a doctor, I don't say, okay, you know, Ben, I need you to go and have a study done to see if you have dementia because I'm seeing these signs in you, as opposed to you, Ben, saying, I'm forgetful these days. Maybe I should go get myself checked to see if I have dementia. Do you see what I'm saying?
Yeah. So that sort of ties in with the understanding about timeliness and people accessing a diagnosis when it's right for them. So it may be that some people say, I'm experiencing some issues, and so that may be, so they may decide not to go and do that because they think, you know, I'm a bit scared, it's stigmatized, it's their choice not to do it. It may be actually that they don't realize that actually this isn't a normal part of aging, this is something different. They may also think there's no cure for dementia, so maybe I don't need to get, and as I was saying, if you're in a rural area, it can have implications, can have implications for your driving license, which may have kind of detrimental impact if you're living in rural areas and you're really reliant on the car. So it's that kind of ties in with a kind of timeliness approach. What government's trying to, or certainly our policy directives at the moment, have been saying people should get it early, and it makes sense with things like cancer, because the earlier you get cancer, the more likely you can live better with it. You may be cured from it. So that kind of policy directive does work for something like cancer, but we don't know, using that same policy directive, whether it works for dementia, because there isn't a cure for dementia, and it is a very stigmatized condition. People report losing friends and social isolation and loneliness following diagnosis. So what we really need to understand is, does that policy directive of get it when you first notice the symptoms as early as possible, does that actually work for dementia? Or is it more timely? You know, you've noticed your symptoms, but, you know, if you can live with them and you're fine with it, then carry on as you are, and then wait till it gets potentially more severe. You might need an intervention of some type. You might need support. You might need to claim some carers allowances or some allowances, which you can only get if you're diagnosed with the condition.
Yeah.
It's,
And
it's an
that's so
interesting
relative,
area.
though.
Yeah.
Yeah, it's a very, I'm sorry, I'm going to shut up because I don't.
That's
Thank you very
fine.
much.
No problem. No problem.
Yeah, Lori, go ahead.
Oh, thank you. Dr. Hicks, I also wrote something into the chat. And so what I'm interested in is, thank you for a very clear and crisp presentation. I'm really interested in timeliness and whether you can speak to the perception of timeliness and the differences between carers who are spouses or siblings, meaning the same generation as the person living with dementia, or whether the carers are their adult children or even young carers, youth carers. Is there anything that you could say about this, or is this a future step that you might want to look at? Because I'm struck by how findings of the carers' perceptions seems to be much more precise or out there compared to what the person living with dementia may have perceived about timeliness altogether.
Yeah, it's a really interesting point. No, it's the short answer to that. I not at the moment. That is definitely something we are going to explore within the data that we have, looking at we're now starting to ask people we're asking people to reflect now over time whether they still perceive the diagnosis to be timely, so 2 or 3 years later, and why they think that is or isn't the case, if it's too early, too late. And we will start to be able to compare that between, as you mentioned, the different kind of demographics of the carers, whether they're spouses or family members, whether they live with the person with dementia or they live away from the person with dementia. At the moment, we don't have anything like that, and I don't think I can even really draw on any other literature, if I'm honest, to answer that question actually. But it's again, it's a work in progress and something we are very much interested in and going to do. And I think also I recently came back from Australia, and they were really interested in this as well, because I think there'll be some cultural understandings and different within different countries about what timeliness means for people as well. So I'd love to do some kind of cross collaboration with other people working in different countries to explore that. But it's a really interesting area. And as I say, and looking at it over time, whether at the point of diagnosis somebody says no, it's too early or too late, but 2 years later, when reflecting on it, do they still think then that it was too late, or would they prefer it to be earlier? I wonder if the perceptions of timeliness change over time as well.
So can you tell us what's your hunch? Like your feeling is that timeliness is such an important construct that we can't make a statement similar to cancer, that the earlier the diagnosis, we know definitely the earlier your diagnosis of cancer, the better kind of quality of life you experience. Although I would say that screening programs for breast cancer have lost their space in Canada because there's no evidence that you get that early diagnosis of breast cancer, that it will make much difference to your life expectancy, shall we say. So your question was, does it matter if the earlier your diagnosis, are you just like with breast cancer, living for 5 more years knowing you have breast cancer versus having any difference in the length of your survival? So we don't this is such a different, unique disease compared to each human being who lives it and their carers. It's going to be very difficult. And that's why there's been very limited publication on that question. Is early good?
Yeah, no, I completely agree. And the difficult thing for me as well is Shubi Banerjee, who leads the project, is all about early. He's written extensively about the importance of early diagnosis from, get it at the early symptomatic stage. Carol Brain, who's the other person in the project, is all about timely. So I've written this paper that we're trying to get out, and they both just keep arguing amongst each other at the moment about the focus of the paper. And I'm stuck in the middle, having to change comments, to change them back, to change. So it's even within our own team, there are big arguments about this at the moment. I just don't know. For me, the kind of the hypothetical reasons for having a better understanding of what might be going on, potentially being able to access some drugs that can slow down the deterioration if caught early enough, being able to access some kind of non-pharmacological psychosocial intervention again, which can support people with remaining physically active, socially active, and to educate people that you can live well with it and for longer with it if you do these things. Then, and that potentially for me would suggest continuing to have an early diagnosis. I think I'm going to stick my neck out, but I'd be really interested to see our longitudinal data over the next few years, and also putting in place services or beneficial supports early on, whilst the person with dementia is still able to communicate and be involved in those decisions. I think that's really important for kind of later down, but also what we're finding from our other work stream, which is one of the work stream 5, which is looking at the decision-making process. A lot of our people, where we're measuring coping techniques and coping styles, a lot of our people are sticking their head in the sand and just not engaging with anything until using any of these kind of cognitive processes to engage with anything until things kind of get to crisis point, and then they look for services or support. So that again is quite interesting. Even once a person's been given the diagnosis, it's how they then use that information again, which is going to be interesting, I think.
Well, I don't feel that there's a single right answer here,
No.
and that it is creating the space where variables from early diagnosis and positive impacts and timely diagnosis there's a space created where features of both of those processes may go forward as being the best approach, rather than a single right answer. There is no single right answer, I think, to these kind of complicated things. Thank you for your thoughts, and I really appreciate how you've been describing your positionality and how this is changing, and you're also having to navigate people with very different opinions that are on the same team. Kudos.
Thank you. Cheers. Thank you, Laurie.
Thank you, Laurie. I'm just going to move on to one more question that we had waiting in the chat by Wendy. Wendy's asking, did the type of dementia affect people's perception of well-being?
I don't know yet. What the type of dementia did affect, though, was the perception of timing. Actually, I didn't have that one in there, did I? It was the perception of timeliness from the person with dementia's perspective. So if it was, in particular, this was Alzheimer's disease compared to a Lewy body dementia. So where people were living with Lewy body dementia, they were more likely to report this as an untimely diagnosis. It's more associated with an untimely diagnosis from the perspective of the person with dementia than if they were living with Alzheimer's disease. And I think some of that probably speaks to clinicians' lack of awareness of diagnosing dementia Lewy body. It's quite difficult, and we've got a really interesting paper which I will forward to Anthea when it comes out, and she can share, which is looking specifically at different sites where we recruited from. Our Newcastle site have got clinicians very qualified in dementia Lewy bodies, and it's noticeable how much more Lewy body dementia is being picked up in our northern site in Newcastle. And also there's a theory around it was an old mining town, and perhaps that has something to do with some of the dementia Lewy body. Anyway, but in terms of your question, I don't know about the well-being, and that's something we will explore, but certainly the type of dementia with regards to Lewy body versus Alzheimer's disease did have some impact or some association with the timeliness measure, from the perspective of the person with dementia.
Thank you so much, Ben. I was kind of thinking that, but nice to hear it. And thank you for such an interesting study and presentation. Really, really nice to hear. Thank you.
Thanks, Wendy.
Thanks, Wendy. Do we have any other questions from the audience? No questions from the audience. Okay.
Alex, I think you have your hand raised.
Yes. Okay. Sorry, Ben, I'm peppering you with all these questions
No
here,
problem.
but you've got my curiosity aroused. It's a sort of a two-part question. The first part is, are there studies similar to this being done in other countries? That's the first part. And then if yes, have you had an opportunity to look at their data compared to your data?
So in terms of other studies, so there is one that has just started in New Zealand at the moment called IDEA program, and that's looking at prevalence rates of dementia. So they're door knocking and trying to identify cases of dementia, and they will then follow some of those people up, looking at well-being and if people receive a diagnosis on well-being. So that's just started in New Zealand, and again, that has very much an inequalities, inequities lens to it, looking at Maori populations, South Asian populations, and New Zealand population. Within that, we were also involved in the STRIDE project, which was a massive project in Indonesia, Kenya, Brazil. Again, like a prevalence study where they were working out numbers of people who may be living with dementia. And again, there was some, I think, what if people were diagnosed, they were looking at kind of well-being outcome measures following that. So there's a little bit. So we do have, I'm on the advisory board for the IDEA project in New Zealand, so we'll be able to feed some of the determined data into that and vice versa. And one of my colleagues sits in the STRIDE team as well. So again, we're working, and Shubi Banerjee, who heads up ours, headed up the STRIDE project. So there are, potential for the data to feed in. The only other one that I know about that was a bit similar to us was again in England, that ran out of Exeter with Linda Clare, called the Ideal Project, which was a little bit before ours, and that again followed people over time, looking more about what it looked like to live well with dementia. So they took people at any point of the diagnosis, the post-diagnostic journey, and looked at how they were getting on and stuff, whereas ours sort of tracks at the very start of that. So there's a little bit out there. I'm not sure about they're only ones that I've sort of been involved in or know about from England. That somebody else may know about other cohorts that are going on in other countries. And if not, we can look to set one up in Canada.
Thank you.
I see an audience question over there.
Our last question.
Some of the reasons that timely diagnosis seemingly benefits the carer and the person with dementia more so than early diagnosis.
Do you want to repeat that?
So they said, why does wait, sorry, can you repeat?
More so than.
Okay, so why does a timely diagnosis benefit the carer and the person with dementia more than the other one?
Yeah, that's a really interesting question. My thoughts are that potentially the carer has noticed the changes for longer. And whether the person with dementia has noticed the changes or doesn't want to accept them, may be why they haven't accessed diagnosis, but the carer has a feeling potentially for longer that something is not quite right, something's been going on. Potentially, and certainly some of the people I've spoken to when we have our participant feedback sessions, and we talked about this then, and they were saying, I was trying to get my husband diagnosed, or trying to subtly drop hints that they may want to go to the clinician and seek some kind of help or referral for a diagnosis, and people didn't for some reason, or maybe it was a bit longer for them, or maybe it takes longer for the person with dementia to kind of come to terms with it. So they might not necessarily feel that the timeliness for them is not the same as the timeliness for carer, who perhaps has noticed these changes for a bit longer. And then when it's reaffirmed, or when it's affirmed to them, you know, that they were right, that there was something, there was a dementia, or there's some challenges, then actually this may then improve the carer's well-being. It may also be that actually, if you're living with it, the carer's noticing these challenges, and then there's a diagnosis, then it may be uplifting for the carer at that point of diagnosis, when they think, okay, now I know something's going on, now I can be a bit more proactive to look for things to do, or understand the condition a bit more, provide better support because I know more about it. So that's potentially why at the point of diagnosis, if it's timely for the carer, it may have more beneficial impacts on their well-being. That's just a theory. I don't know. We will, again, as I say, as we're following people up over time, we'll be able to qualitatively examine this and explore it from our participants.
Okay, thank you so much. I think it's time to wrap up now. Thank you for the wonderful talk, Dr. Hicks, and for everyone who came here today as well as on Zoom. The second seminar for the Gilbert series will be in January 29th. And Dr. Julia Henderson from University of British Columbia will be presenting, and this will be a hybrid seminar as well. So thank you once again, and we hope to see everyone in the next seminar.
Cheers, thank you very much. And as I say, if anybody's got any questions or would like to connect, then please do email me afterwards.
Thank you.
Great, and hopefully I'll see some of you in July.
Yeah. Thank you.
Thank you.